SCCT invites you to Las Vegas for SCCT 2022. Over 3 days, July 15th through 17th, attendees can get a complete overview of the cardiovascular CT field. Planned sessions are targeted for all levels, new practitioners and experienced providers alike. Sessions also range from general overviews to state-of-the-art research and expert discussions. Visit scct.org for more information.
Hello, everyone, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. I am joined by friend and colleague Kashif Shaikh, who has joined me previously as a co-host on the podcast a few episodes ago. Kashif, welcome back.
Hi, Praveen. Hello again to our listeners. My name is Kashif Shaikh, and I am a cardiology fellow at Creighton University, Nebraska, Omaha. On today's episode, Praveen and I will be exploring advanced coronary atherosclerotic plaque characterization and artificial intelligence.
That is right, Kashif. And to provide insight on this topic, we are joined today by an esteemed guest that truly needs no introduction. It is our pleasure to have on today's episode Dr. Jim Min. As I'm sure many of our listeners know, Dr. Min is a prolific cardiac imager who has been pivotal in advancing our understanding of coronary pathobiology on cardiac CT. Dr. Min has innumerable publications in the field, has won countless awards for his academic endeavors, is a past president of SCCT, and is also the founder and CEO of an exciting company in the medical imaging space called Clearly. Jim, welcome onto the Donut of Destiny podcast.
Praveen, it's an honor to be here. Thanks so much for having me.
Thanks so much for coming on board, Dr. Jim. Your career has been illustrious to say the least. Could you give us a brief highlights on your journey in the world of cardiac CT?
Sure. I think it dates back now almost 20 years. There's a guy named Sam Wan, Dr. Sam Wan. I don't know if you know him, but he was at Wisconsin Heart Hospital at the time, and I was a cardiology fellow. He invited me up to a symposium that was showing some 4-slice CT scans at the time. And while I'm sure it was the only good scan that they had that, based on the breath hold that was required for a 4-slice CT, I just felt like, this was the beginning of a technology that would fundamentally change our understanding of coronary heart disease. So I switched over. I planned on going into interventional cardiology and then switched into non-invasive imaging, really to try to adopt CT as a method by which we could better understand coronary disease. So I don't know if you guys know, but I spent about 15 years at Cornell Medical College and New York Presbyterian Hospital on the Upper East Side of Manhattan. And I think the biggest highlights were both, one was research and one was clinical. As we started to try to learn about this technology, I had the opportunity to be part of a team that was a large-scale observational registry called Confirm. And that was probably the most rewarding aspect of my career. It was an opportunity for me to interact with folks globally, just these extremely brilliant folks, and band together to try to better understand coronary disease and to prove out the clinical evidence of its clinical utility. So I think from a highlight standpoint, from a research standpoint, it was probably being a part of that Confirm team. From a clinical standpoint, I think the biggest highlight was actually being able to integrate CT's unique capabilities and unique data that it offers to take care of patients in the clinic. So, we had stood up a cardiovascular disease prevention program about 10 years ago at Cornell called Heart Health. And we really leveraged the CT and the atherosclerosis information to really improve diagnosis, risk stratification, treatment decision-making, and longitudinal disease tracking. So probably those are the two.
Jim, that's awesome. And I think for our listeners, some may have interest in the transition that can be made between academic medicine and industry and still continue to be involved in clinical medicine. Could you give us a couple of words on that, both from your perspective and just in general?
Yeah, I think that's a great question, Praveen. And I think it really just depends on what you're seeking to do, right? I had a conversation This was probably about 4 or 5 years ago with David Newby, who I think everybody knows was the lead investigator for the Scott Hart trial. And we talked about what was the goal of the research that we were doing. And, I think from what we do, which is sort of clinical outcomes research, the goal is really to learn more about new vascular biology and also to try to influence clinical practice guidelines so that we can affect global care in cardiac disease and cardiovascular disease prevention. So that was sort of the first half of my career, which was taking care of patients and really trying to do the clinical trials that would help us understand biology and promote the clinical utility of using this test on a day-to-day basis. And then when I transitioned out of academics, and I haven't fully transitioned out of academics, I still hold a couple of R01 NIH R01 grants and still very committed to the research. But the goals became a little bit different. Now I feel like the second part of my career is really aimed to try to develop products and services that can scale and that can touch any patient across the world. And so that was the major purpose for Clearly. And then from a scientific perspective, really to establish the science to fundamentally change policies so that we can get access to this technology for all sick people rather than just a select group as we're doing today.
Jim, this is great background on your journey through multiple different areas as the field has really rapidly evolved over the last 2 to 3 decades. With that said, let's set the stage for the remainder of our conversation by asking a bit more of a controversial question. Do coronary stenoses matter anymore?
Yeah, that's a great question. I think my answer to that is just one word, absolutely. Everything that we know and that we've learned about angiography over the course of the last 4 or 5 decades has proven to us that coronary stenosis is extremely important. I think that what we also have found through sort of the more recent large-scale clinical outcomes data in the last 5 years or so is that it's really the combination of the stenosis as well as the atherosclerosis, or it's the atherosclerosis that causes the stenosis that represents really the strongest predictor of adverse patient outcomes, heart events. The reason stenosis will never go away is that it is an extremely important metric that we can use to address symptomatic patients with suspected coronary disease. But where I think that the field has faltered a little bit and CT has been really great at sort of illuminating things is that for 50 years, I think we've asked 2 questions and we've conflated them into one, right? So we thought that patients who were symptomatic were the sick ones. And when they came to us, we said, okay, if you have symptoms, we need to relieve those symptoms. And I think that, a stenosis-based paradigm helps us to address that. But we also thought that the relief of symptoms would reduce the risk of future heart events, right? Cardiac death or myocardial infarction. And that has not turned out to be entirely true, right? We know, at least certainly from a revascularization standpoint, whether it's from the ischemia trial, Courage, Berry 2D, Orbita, that we can relieve symptoms, but we don't necessarily reduce risk. So I think what we need to do is extricate those two and look at those 2 questions separately. For a high-grade coronary stenosis in a patient who has symptoms that are suggestive of angina, that we need to dive in deeper to understand that, to relieve their symptoms of angina. And that doesn't necessarily correlate to reduction of risk. That's an entirely different question that I think is largely determined by atherosclerosis.
Right. So, Dr. Min, the coronary calcium purists out there certainly have this question. What more do we gain beyond calcium scoring with advanced plaque characterization on CT?
Kashif, that's an amazing question from a person who's spent many years studying calcium scoring. And I think that for me, it goes back to a quote that Albert Einstein once said. He said, if I had an hour to solve a problem and my life depended on it, he said, I'd use the first 55 minutes to figure out the proper question to ask. And I think in hindsight, both in my own research as well as others, I think the field of coronary artery calcium scoring has fundamentally asked the wrong question. And what has happened is that as a result of that, we've sort of transitioned this personalized medicine tool into more of a population-based one. So let me give you an example of that. Assume 2 scenarios of patients with calcium scores and ask the question, how does that help me, right? So let's say I show you a person who's got a coronary artery calcium score of 200. And the question I ask you is this patient sick? And you'll say, yeah, that patient's sick. They have a calcium score of 200. And I say, well, what if they have gout? Or what if they're on a statin? Or what if they're a multiple marathoner? All things that like increase your calcium score. So you don't actually know, does this coronary artery calcium score of 200 represent somebody who's sick or somebody who's healing? And then you can't actually use this calcium score longitudinally to track therapeutic success, because all the good things that we do for people, exercise, activity, healthy diet, medications, they all convert non-calcified plaques into calcified plaques. And so it's just a difficult question of whether or not this person is sick or getting better. Now assume a second patient that has a calcium score of 0. And I ask you, is this patient sick or not sick? And I think the knee-jerk response would be to say, no, that person's healthy. Like there's this quote unquote power of 0 that's associated with a coronary artery calcium score of 0. I think it's because we don't ask the right question. The power of 0, as it's been espoused in coronary artery calcium scoring, assumes that if you take 1 million people and you find all these people who have a coronary artery calcium score of 0, is their prognosis relative to people who have a higher calcium score good? The answer is absolutely yes. Their prognosis is great. But I think the more important question is not, oh, does the calcium score of 0 connote a favorable prognosis in a large population? But amongst 1 million people who are showing up with a heart attack, what proportion of those people have a calcium score of 0? And it turns out it's somewhere between 25 and 33%. If you look at our data, which was in ICONIC, if you look at MESA, if you look at the Dallas Heart Study, if you look at Cardia, it's about a fourth to a third of patients who present with myocardial infarction had a calcium score of 0. So I think it's just fundamentally asking a different question. And what we should be using is some precision tools that can really hone in on, 1, who is sick and who is healthy, and 2, answer the more fundamental question of MI risk rather than population-based risk. Does that make sense to you guys?
Yes, absolutely.
So, Jim, if I'm understanding correctly, the main method by which calcium scoring is currently used is for proactive prognostication. But rather, what you're suggesting is the question we should be asking is more retroactive for the patients that have an event. Who of them truly had a 0 calcium score? And if that number is not insignificant, then there needs to be more investigation of our understanding of coronary pathobiology and how it relates to calcified plaque. Is that accurate?
I think you're exactly right, Praveen. So, I mean, if you think about risk factors, there was a JACC paper several years ago that showed that about 70% of the people who show up with myocardial infarctions have normal cholesterol levels. So like cholesterol is a great population-based tool to get a p-value when you compare 1 million people versus another million people, or a large group versus another large group. Not a great tool to pinpoint and do precision heart care in a personalized fashion. If you think about calcium scoring, it's definitely a step forward, right? It was because now you miss about a third of the people rather than 2/3 of the people. But it's not an ideal marker. Like if you miss a third of the people, if I remember correctly, a 67% is still a D in school. So I don't think we're doing that well. So I think we have a tool with coronary CTA to really give you a power of 0, right? Where you look at Daniele Andreni's paper or some of Budoff's papers, like what they showed is that there's a 10-year warranty in patients who don't have any atherosclerosis at all. And so I had this luxury of sort of debating Todd Valines a year ago for the ACC education and learning tapes. And afterwards, the moderator, Tony DeMauro, said, well, why don't we just do calcium score? It's a little bit more convenient than a coronary CT angiogram. And I said, well, Tony, like checking for blood in the stool is more convenient than doing a colonoscopy, but we don't do that anymore because even though it's more convenient, it's just not that effective. So I think we've got a great non-invasive tool that, if done right, is actually lower radiation dose than a calcium score, but gives you so much more information to personalize the cardiology care that the CT can offer.
Fascinating. So let's say that our purists concede that, yes, there is an incremental value of exploring non-calcified plaque on CT. Can you summarize for us the validation about these claims regarding plaque and patient outcomes?
Absolutely. Like I think that as I think of coronary disease as it relates to risk, right? Like risk of future heart attacks, risk of sudden coronary death, I think of at least four factors or variables that are important in determining a patient's prognosis. Again, going back to your first question, stenosis severity is certainly one of them. High-grade coronary stenoses are concerning to me, both from a symptomatic assessment standpoint as well as from a prognostic standpoint. Overall plaque burden, how much heart disease you actually have, I think is an important feature. I think the plaque type has been sort of the one that has risen up to the top as being really the strongest predictor of who's going to have a heart attack or which lesions are going to become culprits in the future. And then the most important one, I think, that we don't typically talk about is the rate of disease progression, right? So if you're a rapid progressor of disease versus a slow progressor of disease, you definitely have a worsened prognosis. If you look at Jagat Narula and Sadako Motoyama published a study in the European Heart Journal, there was a more than 33-fold increased risk of future myocardial infarction if you are a rapid progressor of disease. So those are the four things. Of those, none of them can be determined by a calcium score, right? You can't figure out stenosis severity. You can't figure out overall plaque burden. You can't identify the high-risk plaques that are all non-calcified. And you certainly can't assess the progression because, sicker people, as they develop more plaque, they get a higher calcium score, and healthier people that get treated also get a higher calcium score. So I think stenosis severity, plaque burden, plaque type, and plaque progression. We actually didn't know anything about this vascular biology. And I had this opportunity to go on the Today Show and do Matt Lauer's CT scan. And he pointed to an area in his artery that had plaque. And he asked me, hey, is that the good kind of plaque or is that the bad kind of plaque? And I glibly said, there's no such thing as good plaque. But it turns out I was wrong. When you look at the iconic registry, which was a 1-to-1 nested case control study of the CONFIRM registry, what we found was that even when you do a 1-to-1 match of people and make them twins for age, gender, risk factors, even angiographic stenosis severity, that the only discriminator between who will have a heart attack and who will not is the non-calcified fibrofatty and fatty plaque. We saw that in ICONIC. It was the strongest predictor. Maros Forensic saw that in the PROMISE trial. It was the strongest predictor. And Michelle Williams found that in the Scott Heart trial. It was the strongest predictor. And more than just saying, okay, we found some dark plaques that are non-calcified and they're dangerous, what we saw is that you can actually influence the natural history of those plaques by transforming their morphologies from dark non-calcified phenotypes into bright calcified phenotypes. I had the luxury of being part of a group called the Paradigm Registry, and we had used statins to watch this plaque transformation occur as a mechanism of stabilization. But it's been repeated with PCSK9 inhibitors, with colchicine, with icosapent ethyl. There are ongoing studies with inclisiran, and even the DISCO study, which looked at the DASH diet and exercise. All of these good things that we do for patients, they don't regress plaque. They transform it from this dark phenotype into this bright phenotype. And so then if you say, well, how can you use that? For the first time, we have a trackable phenotypic marker of disease that we can see that we're accomplishing one of two goals. One is if you come in with 100 units of plaque, we're going to keep it at 100 units of plaque and halt new disease progression quantitatively. And two, whatever disease is already present, we can stabilize that disease by transforming the morphology into calcified phenotypes. And as I've thought about why this transformation occurs and pathophysiologically what's happening, if you think of the mechanism of myocardial infarction, whether it's plaque rupture or plaque erosion, you need a thin cap, right? And you need a necrotic core or a non-calcified plaque core. And what we sort of talk to each other internally about is we say rocks can't rupture, right? If you have a full rock, you just can't rupture that. And so it fundamentally cannot cause myocardial infarction. So it's those kinds of plaque features as it relates to patient outcomes, I think that really gives the validity of us to use CCTA as a personalized cardiology tool.
That's fantastic. Dr. Min, so how, from a clinical workflow point of view, how do you envision tracking individual patient response to therapy with CT? Would this require serial CTAs in clinical practice? And if you could also talk in the context of calcium progression, seems like calcium progression has a lot of prognostic data from MESA and other databases.
Yeah, I think it's a really good question, Kashif. I think the way that I see it is that I'd like a transparent and full overview of an individual's disease. And if you think about what we've been doing over the last 50, 60 years, heart doctors have never measured heart disease. We always measure surrogates of disease like LDL cholesterol or others. We look at signs of disease like chest pain or angina equivalents. And we look at sequelae of disease like stenosis or narrowings or ischemia. But the actual disease is the atherosclerosis. And everything I know about CT and atherosclerosis is that the brighter the plaque, the better it is. So why I would try to use a less robust tool that doesn't give me insights into dangerous or higher risk plaques, I don't understand a paradigm that would try to espouse that. So would we have to do repeat imaging? I think the evidence needs to bear that out. But it seems to me that what we've thought of, one, we haven't ever measured heart disease. Let's transition into a paradigm where we actually emphasize atherosclerosis as the primary disease target. But two, we also assumed that heart disease was a single disease entity, and it's not. And it's like saying cancer is a single disease entity. There's hundreds of different kinds of cancers, and there's many different kinds of atherosclerosis. And the third mistake I think we made was that things are static. They're not. What we do is as we exercise, you see changes in your atherosclerosis. As you get treated with medications, you see changes in atherosclerosis. So the dynamic nature of this disease process necessitates that we have to follow this longitudinally and not just look at somebody at a single point in time.
So, Jim, Kashif and I wanted to pitch two clinical scenarios to you just to get your idea as to how this may work in clinical practice. The scenario that I'd like to bring up is one of potentially discrepant diagnostic data. So let's say we live in a world in which we are serially tracking what is happening to a patient's plaque pathobiology by CT. We find a patient that has a heavy amount of coronary athero, definitely some suspicious features on advanced plaque characterization, but at catheter angiography, there's no hemodynamically significant stenoses, and at stress testing, there's mild ischemia. How might a clinician approach the next both diagnostic and therapeutic steps in that particular patient's case?
Yeah, I think that's a really good case to sort of dissect what we're trying to do. And I think it highlights, Praveen, the things that, this conflating two questions into one that we've done over the last 50 years, which is, hey, if somebody's symptomatic, then they must be at risk. That may be true, but relieving those symptoms doesn't necessarily reduce that risk. And so I think that there are subsets of folks out there who are prime candidates for angiography and revascularization. And I think what we need to do as a field is shift this paradigm that says that you have to have symptoms in order to be sick, because you don't. Like the vast majority of people who have atherosclerosis don't know it. And the majority of people who will suffer myocardial infarction or sudden coronary death don't actually have any symptoms before their event. So as a field, let's knock down this artificial wall that says that you have to have symptoms to be sick, because it's just not true. But in the symptomatic patient, I think that person requires assessment. And if they are symptomatic and they're refractory to medical therapy, then yes, I think relieving angina and chest pain is an admirable goal, and we should send those patients for revascularization. I also think that if you go after a disease-focused paradigm rather than a symptom-driven one, there are millions of people out there in the United States alone who are walking around with severe triple vessel disease and left main disease that I suspect will highly benefit from coronary revascularization. That said, the vast majority of the people who come in, as you said, with some mild ischemia on stress testing, but severe coronary atherosclerosis, initial medical therapy, I think, is the way to go. And the corollary to that is, if I hear one more time somebody said, well, I put them on a statin, like what else can I do? Like we have over a dozen different families of medications that we can use to prevent this. And it really goes back to sort of the mid-2000s when Peter Libby wrote a beautiful editorial in JACC called The Forgotten Majority, where he talked about us putting people on statins and lowering cholesterol, but it's a 20% relative risk reduction. That means we failed in 80% of the people. And given that we have PCSK9 inhibitors and inclisiran, icosapent ethyl, GLP-1 receptor agonists, SGLT2 inhibitors, and so on, we have so many different new blockbuster medications that we can use to reduce risk. And so a mild ischemic stress test doesn't concern me so much. Refractory symptoms concerns me because that patient is in pain and we need to relieve that pain. And then in terms of reducing risk of heart events, to me, that is in patients with severe angiographic coronary disease. I believe that they would benefit from coronary revascularization. And then in the vast majority of others, it's a medical therapy lifestyle intervention question to reduce risk. And again, trying to separate those two questions of how do I relieve symptoms and how do I reduce risk?
That's fantastic, Dr. Min. Hey, here is a second scenario I wanted to ask you. It's more so an asymptomatic population. It's related to a situation that I saw in clinic recently. It's a 43-year-old South Asian male with a very strong family history of heart disease, including sudden cardiac death in his grandfather and fatal MI in the father. He underwent non-contrast CT and calcium score is 20 Agatston units. That puts him at 85th percentile risk. He's already on high intensity statin, leads a very healthy lifestyle. How could advanced plaque characterization further help in risk stratification?
It's a great scenario. And I think the answer to that is we don't know. We don't know until we actually take a look, right? So if you take a look at that person with a more comprehensive test than a coronary artery calcium score, i.e. a coronary CT angiogram, and that 20 units of plaque, a calcified plaque is all you see, well then great. I think that you've figured out that this person actually probably is at a lower risk as compared to what you would have expected from his family history. But if you go and you look, because this person's younger, remember the calcium is an age-dependent phenomenon, right? So it tends to be present in older people, but not necessarily in the younger folks of the 43-year-old patient that you've described. Maybe there's a tremendous amount of non-calcified high-risk plaques there. We just don't know. And that's the point, is that you don't know until you take a look. And you can't take a look with shortcuts. You have to do it comprehensively.
So, Jim, I want to shift gears here a little bit, away from some of the more concrete science into what we anticipate for the future logistically. All of us are imagers here, and we know that imagers tend to be pretty stubborn in how they do things. Let's say that these tools are available through a new software platform. How are we going to get some of these stubborn imagers to integrate yet another software into their clinical workflow?
Yeah, I mean, Praveen, that's a great question. I think the answer to that is let's not try to make more stuff. Let's try to consolidate everything and actually make an all-in-one turnkey solution that gives you every actionable insight related to coronary heart disease. I think we can do that with CT. I think about sort of CT or coronary disease in three sequential steps. The first is, what is the primary disease? That's atherosclerosis. And so let's characterize that whole heart, every artery and its branches. And let's provide the information related to disease burden, disease risk, things like that. And then the second is, the atherosclerosis may encroach upon the lumen and causes stenosis. So we've got to provide that. And then we have to figure out whether or not in the symptomatic patient, which is the minority, but we do have to figure out whether or not the symptoms are related to that coronary disease. If you can get all three of those things in one, then you just need the one software or the one solution. You don't need three solutions. As I look forward, like Peter Stone and I, Peter's at the Brigham, he and I are doing a project related to endothelial wall shear stress. So local perturbations in coronary hemodynamics, I think is something important. That's the one that I see maybe clinically useful for figuring out progression and risk. But right now, I think it's more of a research tool. So if you can give them users a tool that does all three of those things, the primary process atherosclerosis, secondary anatomic consequence stenosis, and tertiary physiologic consequence ischemia, in a very easy to use solution, I think you've reduced the number of softwares, not increased them. In our company, we knew that people would say well, how do you know stuff is good enough? And so, our CMO has been brilliant at running a series of large-scale multi-center trials against every gold standard, whether it's expert readers, IVUS, OCT, CAP, NIRS, or FFR. And I think it's that kind of clinical trial validation associated with a turnkey user experience that people really enjoy, and then consolidating these tools into a single one that gives you everything that you need to know related to coronary disease. And then on the flip side of that coin is the practicality of it, is that there's there's a financial sustainability model that has to occur so that, doctors and cardiologists can practice in such a way that the work that they do, which is so admirable, is actually compensated for that. And so I think that there is a financial alignment that will also encourage widespread use.
All right, moving on to next question, Dr. Jim. This wanted to ask, what are you most excited for in the future of coronary imaging space generally and AI in imaging specifically?
Wow, Kashif, that's a great question. I think what I've observed in the field over the last 5 years is that there's been a lot of tools, whether you look at cardiology or oncology or neuroimaging, and they all historically started at the same place where they automate image segmentation, right? They do computer vision image processing. That was the first step. That was the foundational step because it allows you to comprehensively and personalize phenotypic analysis of somebody's disease. I think that's where we're at today for the most part, where these tools are better, they're more accurate, they're superhuman, they improve efficiency of the doctor, and they can make doctors' lives better, and we can get more information. I think the next era or the next stage of this field is where AI will beget AI to allow us to personalize cardiology care. And what do I mean by that? What I mean is that the AI that we use today is literally used to segment images and provide quantitative outputs of phenotypic disease. I think once we get this comprehensive phenotypic analysis, we can now leverage this as inputs. So the AI outputs of the first algorithm are the AI inputs of new algorithms that do clinical predictive analytics, right? Predict heart attacks, identify medication non-responders. I think those kinds of things are going to marry the AI with large-scale outcomes research, and that will be very exciting. I think in parallel to that, what we're going to see is that the machine learning or the AI will allow us to do what I term multidimensionality data reduction, right? We have so many different dimensions of data in healthcare, in a patient's life, whether it be imaging data, laboratory data, epigenetic, proteomic data, omics data, wearables data, patient self-reported symptom data. And there's just too many dimensions of data for us to be able to aggregate it, integrate it, and then output it in a way that's simple to act upon. So I think this whole reducing all the multidimensionality features of all of the data that we're confronted with on a daily basis will help us take better care of patients. I think that will be very interesting. So I think it's those two parallel avenues that I find to be most exciting.
Excellent. Thanks for the insight on what we're looking for in the future for that, Jim. And in light of that, a lot of our listeners are early career physicians and trainees that are anticipating going into cardiac imaging. Wanted to get some of your thoughts on what they're probably going to see in their lifetime, as well as any recommendations you may have for how they should approach the field of cardiac imaging.
Okay. Yeah, that's a wonderful question. I think as I think about it, I think this AI is going to be like cell phones, right? You got the cell phones. The next year, you got another cell phone that was slightly better. The next year, you got another cell phone that had a couple more features. And then, boom, all of a sudden you saw the iPhone and you had an entire computer in your pocket. And it didn't go iteratively. It just went to a brand new 10x better plane where you saw something so I think there's an activation energy that occurs. And then all of a sudden you see complete disruption in the field. I think that's what's going to happen with AI. I think it will be the biggest revolution that we see in our lifetimes in medicine, where we can finally process this data and then try to develop solutions that can give sort of outputs that can be clinically actionable. In my own case, I came into the field at a very early stage, and I've often thought about this, what would have happened had there not been CT? The articles that I wrote as a fellow were solely concentrated on nuclear SPECT imaging because that was the tool we had to assess coronary disease. And I was lucky to be part of a new discovery of a new imaging modality that helps better phenotype and understand coronary disease. I think that those opportunities don't come along that often, but there's always opportunity. I think if there's any advice I can give to anybody is find the unmet need, right? If you can figure out the unmet need, it's not about a CT scan. It's not about a calcium score or a CT angiogram or an MRI. It's about figuring out what is the clinical unmet need. And then you can always find the tools that help you answer those questions. I think to that end, I would encourage people challenge dogma, right? Like when I was training 20 years ago, we were firmly convinced that ischemia-guided revascularization saved lives. It does not save lives in stable patients. Everything that we're taught isn't necessarily true. And I would encourage the listeners to not only challenge dogma, but to challenge yourselves. In my own case, I spent 10 years studying calcium scoring only to realize that I don't think it's a very good tool to use for patients with suspected coronary disease. And so just to always question things and always ask why, right? Like if in the case of ischemia-guided revascularization, for example, we thought ischemia, we call it ischemic heart disease. We thought ischemia was the risky part of it. It turns out when you ask the question, is it the cause or is it the effect? It turns out it's probably the effect, where it's the effect of atherosclerosis on coronary hemodynamics. And so if we can constantly ask why is something occurring that way, I think it will conjure up the clinical questions that are important, that allow you to address the unmet need and also challenge dogma.
Great. Dr. Mann, this has been really excellent. Thank you so much for giving us your precious time and expertise.
Yeah, Kashif, thanks so much for including me. If I can just leave with one thing, it's I forgot to also make this recommendation to your trainees and the early career imagers. But for me, at least, all of the questions came from the patients, right? So when you're seeing a patient and you're confused about, their presentation or what you should do next, that's, I think, where the important clinical questions come from. So if there's any one sort of summation piece of advice I might give is listen to the patients, because they're the ones with the most important questions.
Jim, truly thanks again for coming on to the podcast. Any concluding remarks?
Just thank you for having me. It's a really, really exciting time to be in the field of coronary CT angiography, riding a lot of secular tailwinds on the American Heart Association guidelines changing, the Society of Cardiovascular CT releasing their documents on atherosclerosis imaging, and similarly, the American Society of Preventive Cardiology. I just feel privileged to be part of a groundswell that are sort of shifting the paradigm towards measuring actual disease rather than focusing on just symptoms. So thank you again. It's been a privilege to participate in this podcast.
Truly, thank you, Jim, not only for coming onto the podcast, but for your contributions to the field for the past many years. Kashif, of course, thank you for co-hosting with me. To our audience out there, thank you, as always, for tuning in. If you like what you hear from us, please rate, review, and subscribe to the podcast. Once again, this is the Donut of Destiny. Cheers.